This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. A 65-year-old lady has had an episode of acute angle closure glaucoma a couple of years back, and she's undergone iridotomy for the same. Her pressures are under control with medications, and now she has come for cataract surgery, and this is the picture. Pupil dilatation is limited. She has got pseudo exfoliation, and the cornea generally doesn't look to be very healthy. Of course, we have a shallow antechamber to deal with. The other eye is a primary angle closure suspect with the iridotomy with early cataractous changes. So again, let us write down the plan for the surgery now. We need to plan and deal with these issues. The major issue here is going to be the pupil. And to dilate the pupil, I'm going to do a stretch pupilloplasty and then use a pupil expansion device. In this eye, I'm going to use a BX ring. I don't expect any major problem in rest of the cataract surgery. I expect the zonules to be very good because the slit lamp examination does not reveal any evidence of phacoemulsification. So let's see how things turn out. The surgery is being done under posterior subterenous anesthesia. The two side ports are made. When you're making the side ports, I need to be mindful that the antechamber is shallow and there's always a risk of touching the iris or the antercapsule during introduction of the blades. The chamber is stained with trypan blue under the air bubble. At this point, I know that only the central part of the antercapsule is going to be stained and not the peripheral part. I am planning to restain the peripheral part of the capsule after stretching the pupil. So before stretching the pupil, I need to put in OVD into the chamber so that the chamber is pressurized and deepened. I'm going to use 2 Y hooks to perform the stretching. The Y hooks will engage the pupillary sphincter, and I'm going to stretch the pupil across different meridians. So while stretching, I'm not very conscious of extending the stretch all the way up to the limbus. I'm just stopping short of limbus. I feel that this much stretching should be able to provide us bigger dilatation after we use a pupil expansion device. The main incision is created. Now we can see that some of the capsule is still not stained, which was hidden under the pupil. So I would like to restain the capsule. Going with my irrigation cannula. Using just passive irrigation, I want to get rid of the OVD which is there in the antechamber and also which has coated the antercapsule. By doing so, our chances of getting the stain to stick onto the capsule would be better. Restain the peripheral part of the capsule with trypan blue under the air bubble. Now OVD is introduced into the eye. Now at this stage, the pupil looks to be fairly big enough to continue with the surgery. But still, I would like to go ahead and use an BX device simply to prevent the pupil from coming down, and BX device is going to help me to retain this pupillary size until the end of the surgery. And the second aspect would be whenever we stretch, some of the pupil have a tendency to become floppy. So this device also has an advantage of minimizing the chances of floppiness because the notches are going to be engaging the iris. So that is one way of minimizing the chance of a floppy iris developing after stretching. And of course, the major advantage is I'll be rest assured that intraoperative meiosis is unlikely to happen. Time to perform the rhexis. I'm aiming a rhexis of about 5 mm in diameter, and the zonules are very healthy. This is what I realize as the rhexis is being done. So no concern on that part. A gentle hydrodissection is performed. The nucleus is tapped back on the other side so that the capsular bag decompresses. And now we have a nucleus with its cortex free from its attachments to the bag. A time to perform a phaco. The superficial epinucleus and the cortex is aspirated out. Before doing the primary chop, I'm going to create a small central trench which is about say 30% depth. This much depth is good enough because the nucleus is not very dense. Now is the time to perform the direct chop. The tip is buried into the substance of the nucleus using longitudinal energy. The sharp vertical chopper is placed just in front of the phaco tip. The chopper goes down vertically while the right hand with the tip is held steady or moved slightly upwards. And then there is a lateral separation maneuver being done by my left hand. The chopping process is continued. The tip is buried into the substance of the nucleus, the chopper is placed exactly in front and opposite to the phaco tip. The chopper goes down vertically and then there's a lateral separation maneuver. This process is continued until we have around 6 smaller fragments. Now is the time to emulsify. Each of these fragments is then pulled out of the bag and emulsified at the level of the iris plane, and these are the settings for emulsification. Here we'll be using torsional energy with a reasonably high flow rate in vacuum. Once half of the nucleus is out, I feel that the emulsification is happening more anteriorly than what I would have preferred, and there's a reason I want to replenish the chamber with some OVD so that the cornea gets protected. Now the emulsification process is continued. The last fragment is out. There's epinucleus which is gently irrigated out. Now we're able to see the posterior capsule and there's a red glow, and there is evidence of asteroid hyalosis. In all eyes with asteroid hyalosis, we need to be a little bit careful. There's a higher risk of posterior capsule tear happening simply because we feel that the posterior capsule is slightly thinner in eyes having asteroid hyalosis compared to a healthy one. Nevertheless, each bit of cortex is aspirated out. Time to implant the lens. The planned toric intraocular lens is placed into the bag. Time to remove the BX ring. So I would prefer to remove the BX ring when the OVD is still there in the eyes. So using the forceps, the device is disengaged from the pupil and then pulled out. Well, removing the BX device and pulling it out of the eye, the maneuvers are so simple. This is one of the biggest advantages of BX device compared to its competitors. The OVD both in front and behind the lens is irrigated out. Once it's certain that most of the OVD is gone out, now is the time to align the lens into the intended axis. With the irrigation cannula through the main incision itself, I'm just nudging the lens so that the mark on the lens corresponds to the mark of the intended axis. The lens now looks to be very well aligned. Time to close. Both the side port incisions and the main port is hydrated. The pressure is checked, looks to be alright. Intracameral antibiotics are given, and that's it, the case is done. So these are the post-op pictures. The first day had some corneal edema, and by third day the edema had cleared and the patient continues to do well. Well, to summarize, cataracts in angle closure disease can be challenging. In this case, the only challenge we needed to have was to deal with the pupil. So after doing a stretch pupilloplasty, I used a PHEX ring to maintain the pupillary size, and rest of the procedure was uneventful and quite easy to perform. So that was it. Thank you for watching and hope you found this helpful.